Yeah, so Stockholm3 is a blood-based test that has been validated in large studies in Sweden and is commercially available there. And this was a large, diverse North American study looking at men that were going for biopsy of their prostate based on a clinical suspicion of prostate cancer. And the intent was to evaluate its role in finding grade group 2 or higher, but potentially minimizing the need for men to undergo biopsy. And the test itself is 5 proteins, which include total PSA and free PSA, 101 SNPs, and then also some clinical factors like age, whether they had a previous biopsy, and family history. Yeah, that's one of the attractive components of the study. There are a lot of biomarkers and genomic classifiers and even medications, therapeutics that aren't sufficiently studied in a diverse cohort. And so there's always questions that come up, will it work similarly in underrepresented minorities? And so one of the great parts of this cohort is that it was enriched for groups such as Black men, Hispanic men, and Asian men. And less than half of the population were white men, which is atypical in this space, but great to see. Yeah, so the good news is, there were pre-planned subcohort analysis, and in each racial and ethnic group, the test seemed to perform similarly compared to the overall cohort. So there was no signal identified that it might be better or worse in certain populations. But translating that into kind of real-world clinical care, if one strategy is biopsy everybody with a suspicion of prostate cancer based on PSA or DRE, and then the standard, which we used in this control arm, was if their PSA was greater than 4. So that was kind of the benchmark because that's clinically used. And then Stockholm3 was evaluated in comparison to that PSA threshold. And using a Stockholm3 level of 15 as your cut point, the relative sensitivity of capturing grade group 2 or higher was roughly 92% of if you used PSA level of 4. But the specificity was about 3 times higher. And what that means is it translates, if going forward people use Stockholm3, if you use that cut point of 15, it appears that roughly 40 to 50% of the population wouldn't necessarily have to undergo a biopsy. And you still capture nearly all of the men that have grade group 2 or higher. So biopsy itself is overall safe, but there's some pain component. There are some risks to it where you can see blood and certain substances afterwards, and there's a very low risk of infection. But by avoiding a biopsy, you're hopefully avoiding a benign biopsy, meaning you had it, you got good news, but then you question why you needed it, or a grade group 1 diagnosis, which typically is managed with surveillance, and a lot of the attractive parts of biomarkers or MRIs are trying to minimize the number of men that are diagnosed with grade group 1. And you still capture nearly all, not all, but you're still capturing the main cohort of men who have grade group 2 or higher, which are the ones that you want to identify with PSA screening. The intent of the company is based on this cohort going to payers and people who approve these things and making it commercially available sometime this year in the US. Now, tests such as this, which we think of as secondary biomarkers, you get a PSA, and if the PSA is abnormal, sometimes you go get a secondary biomarker such as Stockholm3. But there's many other examples that are already on the market. And the intent of all these biomarkers is to try to still capture the grade group 2s, but minimize the total number of men needing a biopsy. And no one knows head-to-head how these biomarkers work, but they all have trials supporting them. And now, thankfully, in a North American cohort, we have supportive evidence for Stockholm3.